good. Thank you very much for inviting me. Let's crack on again. I'll just go over my initial slides again for everyone that hasn't joined us. So I run a headache clinic for NHS Devon. I've been involved in headache for many years now. I've been involved with the Royal College of General Practitioners, the British Association of Study of Headache, and I'm what's called a general practitioner with a special interest. So if anyone wants to Google our headache clinic, there's lots of information, videos, management plans, and lots of patient information sheets that you might like to browse, and lots of links that you might be interested in. So I'm going to take my talk in two halves. The first half will be about diagnosis. The second half will be how to live with your migraine. So I think this is a useful framework to look at medical presentations, look at medical presentations in terms of three elements: the disease, the illness, and the sickness. So the disease is what the doctor sees. This is what the diagnosis is. It is the migraine, which the doctor treats. But as you're all aware, I'm sure, migraine is very much more than just a headache. And this is the illness, what the person with the problem experiences. And from the medical perspective, we'd call this a migraine a complex psychosocial issue. Okay, some people have just pure migraine biology, but there's a lot of issues with anxiety, quite understandably, and depression. And there's also lots of impact in many cases on people's social lives, their occupational lives. So the illness is the complex picture that a person experiences. And migraine also comes with a lot of other illnesses, which I will allude to shortly. So migraine is certainly, as I'm sure you're all aware, a lot more than just a simple headache. And there's the sickness, which is how society views the illness. And in areas such as migraine and mental health, things you can't measure or put a number to or take an X-ray of, things like this get quite stigmatized. Things are an awful lot better nowadays, but certainly migraine has historically been quite stigmatized as, it's only a headache. What's the problem? So let's think about why we actually need a diagnosis. Well, we need a diagnosis. It's important to label things, first of all, to get an understanding of what's going on. And by getting an understanding of what's going on and putting things into boxes, we can measure the impact and the importance of those particular clinical areas. And by putting things into diagnoses and boxes, this gives us opportunity for cure or treatment as we move forward. And this approach has been around for thousands of years. The ancient Greeks on the left made diagnoses in terms of whether things had excess of bile, the yellow bile, black bile, phlegm, or blood. And the Chinese system of medicine looked at diseases in terms of a balance between yin and yang and the energy channels through which this energy flows. And in acupuncture, very much is underpinned by this theory of disease. So putting things into disease categories has been around for thousands of years. But today we take the approach of what we call modern science. It started in the Enlightenment, late 18th century, so 17th century. And this is how we formally now classify our headaches for diagnostic purposes. We diagnose headaches in terms of secondary headaches and primary headaches. So a secondary headache accounts for a very small number of headaches, less than 5% of all headaches. These are headaches where you can actually identify an underlying problem. And usually by removing that problem, you can cure the headache. So such examples would be a headache following a trauma to the brain, a vascular headache. You might have a headache due to inflammation of the arteries or a bleed in the brain. Non-vascular, you may get a headache due to some sort of lesion that's expanding inside the brain. Substance-induced, an example of a secondary substance-induced headache, probably the most common one would be alcohol, the sort of Sunday night hangover, so Sunday morning hangover. A secondary headache from the infection perspective would be meningitis, disturbed biochemistry, renal failure, or headache arising from some sort of facial structure, teeth problems, problems with your jaw joint, sinusitis. These are secondary causes of headache. But the headaches we're primarily focused on are primary headaches. This is the problem. 95% of headaches sit within the box of primary headaches, and the three subdivisions of primary headaches are migraine, tension type headache, and cluster headache. And primary headaches are headaches where although we're beginning to unpack what's happening, there is something happening at the level of the cells, a really microscopic level, at a biochemical level, that we're beginning to understand, but we still don't have a clear picture of. So these primary headaches are classified according to how they present, the picture with which they, or the pattern with which they present with. So these are the three primary headaches. There are a number of other less frequent ones, but these are the three most common ones that we are dealing with. and we are diagnosing these on the basis of the patterns, the clinical patterns. So migraine, probably about 14% of females, 8% of males. Tension type headache, quite common in the population, about 70% each year of the population will have a tension type headache. These are ordinary, featureless, dull headaches, usually like a band pressing. They just last a few hours, take a paracetamol and they'll go away. I think in many cases, I very rarely diagnose tension type headaches because in many cases, these are all part of the migraine spectrum. I see very much migraine and tension type headaches sitting on a spectrum, but the headaches that are very different occur in about 0.1% of the population each year are cluster headaches. And often people get confused between cluster headaches and migraine. The difference is very distinct. I think one of the problems is that migraines sometimes can come in clusters. You can have a run of migraines and you have a clear patch. And lots of people say, is this cluster migraine? Now, migraine and cluster headache are very, very distinct. I know migraine is very painful, but cluster headache is arguably the most painful condition known to man. It's called suicide headache. It's very different from migraine, but the real big significant feature is when you have a migraine, as I'm sure you're aware, you want to lie down, pull the curtains, turn the telly off. With cluster headache, you're agitated, you're pacing the room, agitated, restless, often aggressive, and you're not going to certainly want to do that when you've got a migraine. So I won't say anything more about the other potential diagnoses. We're going to focus on the primary headache of migraine, which really takes up about 95% of our primary headache. So migraine for problematic headache is by far the most common problem, both in terms of population and in terms of people that come to see their GP. So when people come to see their GP with headache, what do they think they have? Well, a lot of people don't realize they have migraine. Obviously, many people do, but often the main starting points are, do I need glasses? And many people have been to see the optician, which is useful because they can have a good look at the back of their eye. But the number of people that have headache from refractive issues is quite small. Could it be my blood pressure? If your blood pressure is very raised, significantly raised, clearly that's going to give rise to headache. But for moderate and mild hypertension, it's unlikely to cause you headache. And the problem that everyone is concerned about, both doctors and patients, is, do I have a tumor underlying my headache? And fortunately, brain tumors are very, very rare. Clearly, they do occur. And there are certain specific features that would indicate there may be cause for concern here. But if you've had your migraine for a number of years, the pattern hasn't really changed very significantly. You can almost be, we can never be 100% sure, but you can be fairly sure that there's nothing serious going on. So that's what people tend to think when they see the GP. What do the GPs think when people see their GP? Well, we did a big study in Exeter. It was a database study. We looked at a computer database study. We looked at 96,000 new patients that came to see their GP with headache. And unfortunately, the GP, in the majority of cases, the GPs didn't make a formal diagnosis. The study now is a little bit old. It's about, I think, 10, 15 years old, and hopefully things have improved. But unfortunately, GPs and medical professions are not always 100% on making diagnoses. So what do people who see their GP actually have? Well, 95% of them will have migraine. So wherever you look, migraine is the default diagnosis. The most common cause of headache that goes into casualty is migraine. The most common cause of headache that sees specialists, secondary care in neurology is migraine. So really any episodic headache, which is problematic, whichever setting you look at, is going to be migraine. So I alluded to the fact that our primary headaches, we can only make the diagnosis by recognize the clinical pattern. So what happens, there's no absolute right or wrong here. What happens is a group of the great and the good of the International Headache Society sit down and decide what the formal diagnosis of migraine should be. And here it is. This is our formal starting point. And this would be the starting point you'd use for a research study if you're trialing a new migraine drug. You would ensure that everyone has formal migraine. So you have to have at least 5 attacks. Clearly, the GP will make a diagnosis with less than 5 attacks. Your headache has to last between 4 and 72 hours. In children, slightly shorter, 1 to 72 hours. But migraine, as I'm sure you're aware, can be longer or it can be shorter. You have to have 2 of the list on the 3rd line and 1 of the list on the last line. So that is what you need to have actually formal migraine. In practice, you can relax that, and we do in clinical practice, because any recurrent headache that bothers you, which is associated with nausea, or if light and sound or movement or touch bothers you more when you have a headache than when you don't have a headache, you can bet your bottom dollar that that is migraine. So that's a much simpler diagnostic tool than the formal tool that I've alluded to on the previous slide. There's quite a few problems with diagnosis. Many people don't realize they have migraine. This was common it's better now because everyone's got access to the internet and most people have Googled their problems. So but still people don't realize that they have migraine. It's just a headache. It's not life-threatening. It's going to go away. A lot of people realize they have migraine but don't seek help. We realize that less than 50% of people with migraine will actually go and see their GP. And as I've alluded to previously, when they go and see the GP, the diagnosis is not always clearly made. So it's a problem that I've been dealing with for many years now with my hat of the Royal College of General Practitioners on. We are making slow progress, but I'm afraid there is still a long way to go. Okay, so that's just a simple whip through diagnosis. The diagnosis of migraine is usually pretty straightforward. And our suspicion is alerted even more if there's a family history of migraine. If you have a parent or a sibling that has migraine, you have an 80% chance that migraine will be carried through to the next generation. So there's certainly a genetic predisposition. It's not a one-for-one simple relationship, but we do recognize a genetic familial relationship. So if there is there's almost certainly going to be a family migraine genes if you have migraine, if you look back. I want to just, on the next slide, just reflect a little bit on a journey that I'm sure many of you will be aware of, the long and winding road, the person's journey with migraine. I think this is a really interesting thing to unpack because in medical practice, we just take snapshots of people's lives. We don't see the whole picture, and there've been no studies that looked at the whole picture. And I just want to highlight some of the things that are important as you go through the migraine journey. And I'm taking a female here, and this is time along the bottom between the age of 10 and 60 years. And this is migraine frequency on this axis here. So the most common age when migraine starts is in fact early teens, 14, 15, certainly with females at the onset of their menstruation. So migraine starts kicking in at about the age of 15. And then often people go away to university with increasing pressures and the stresses are on. They may see a GP at this stage and get a little bit of benefit. And then with females, first pregnancy comes along, and usually in pregnancy, most commonly because of this estrogen sensitivity, which remains stable during pregnancy, the migraine will go down during pregnancy. They finish their pregnancy and breastfeeding. Migraine starts triggering up and down again. They go and see a GP, don't get really much success, get referred to the hospital. Most neurologists, I'm afraid historically, have not been particularly good at managing migraine. You usually get an inappropriate brain scan and sent back to their GP. And then, so 50 years old, the menopause starts, or what's called perimenopause, around the menopause. And it's this fluctuating estrogen that happens during the menopause that causes problems. So headaches get worse. And they see a GP who decides they need some HRT and things settle down, but then the GP moves on or the patient moves on. And so things get worse again until finally, as the estrogen settles down, as they go through the menopause, as they reach their 60s, migraine settles down. So you can be optimistic that migraine will get better with age, but in some people, there's quite a long time to wait. And in some people, migraine actually is quite rare, but migraine can go on into later life. And in my career, I think migraine is probably the only thing that gets better. Everything else, I'm afraid, gets worse. But I think that's a journey that is an interesting one. There's no real excuse for it. And it sort of really recognizes the importance of getting hold of things early. There's no evidence to suggest that if you can diagnose migraine early, it's going to cure the migraine in the longer term, but you get more control and understanding of it. So you exactly know what's happening. You can get good medication on board because the majority of people who start their migraine here will actually go on to get migraine throughout their lives. So that's the migraine journey, which I'm sure many of you will recognize in various parts. So let me shift on to the second part, and this is the tricky part. I want to just pick out some themes here. So I want to pick out 3 themes on how you might live with migraine. So first thing to realize is you're certainly not alone, and often, that's reassuring. The second element is that we need to realize that migraine is not just a headache, but a disease to be taken seriously, and you need to look at all the other things that are going on. And I think the third important thing to realize is that at the moment, and obviously there's lots of research going on, there is no cure for migraine. And I'm afraid there's not going to be any cure, certainly in the sort of short to medium term future. So the focus for our migraine is what we call shifting the locus of control. And I quite like this concept. So we need to take control of the migraine rather than it being in control of us. So I think those are the three themes I'd like to focus on. So let's just think about you're not alone. This shows how many people have migraine in any one year as a function of age. And you can see that certainly in females at the age of 40 to 50, which is a hugely demanding time of their life. Let me just pick up a pen if I can. Over 25% of the population will have migraine. So there's all sorts of things going on here. The menopause is approaching, children are leaving home, stresses of work and family. And over 25% of the population of females will have migraine. It's a lot of people. And you can see males at all age groups are lower prevalence than females. And with time, the migraine prevalence actually tails off, although still at the age of 85% of the population will have migraine. So there are a lot of people with migraine. We've done quite a lot of research in Exeter, just to give you a snapshot of what's going on. These are people on the transition between childhood and adulthood. We did a big study. We look after the University of Exeter, and we did a big study of students coming into university. And we looked at just over 1,000 consecutive students, and this figure of 21% here comes in. Every study we do in adults, in children, and in these students, 21% of students had headache that impacted upon their quality of life. And for 13%, this was quite significant over 15 days of the month. Going back to, I said about people seeing their GP, less than 50% had seen a GP, and less than 5% were actually on prescribed medication. So lots of people out there had problems. What's the impact in the world? Well, every so often, the World Health Organization puts together what's called a Disability Impact Index. And this ranks, there's a technical way of doing this, which I won't do. This ranks the disability of various diseases in the world. And here are the two rankings in terms of 1990 and how they changed between 1990 and let's get a pen again. This column is 1990, the leading causes of disability, and this shows how things have changed up to 2013. And you can see that in both these times, migraine is number 6. These are quite interesting to see these lines that show how things have been increasing or decreasing. So the other thing to pick up here is medication overuse headache. We'll talk about that in a minute. Is coming up from 27 to number 18. If you look at the age group, this is all adults. If you look at the age group for young people under 25, migraine will be up at number 1. So it's quite interesting to look at this slide. In fact, so we can see an increase in depressive illnesses as there's more stress around. Iron deficiency anemia is going down. Diarrheal diseases are going down quite significantly, and this is reflecting the fact that we're beginning to get to grips with sanitation in poorer countries. What about the things that are going up? So diabetes is going up, which is reflecting our increasingly unhealthy lifestyle. Osteoarthritis is going up as we're getting older. What else is interesting? Mental and substance abuse is going up, and Alzheimer's is going up as well as, again, we're going older. So it's quite interesting. Other interesting thing just to flag up, war is going down. Disability due to war injuries and deaths is going down. So that's quite a little interesting study, but it just reflects the fact that lots of people have migraine, and it is a very significant impact upon people's lives. Number 6 in the world, and in under 25s, number 1. So my second point is migraine is not just a headache, but a disease to be taken seriously. This is because it comes with lots of other diseases we call comorbidities, with morbidities, pathologies. So there's lots of other diseases that have a much higher frequency in people who have migraine. This may be due to the fact that there's similar genetic mechanisms. It may be due to the fact that migraine may be causing these other problems directly. So these are the migraine comorbidities that are most common, although the list is actually bigger than that. So I'll put anxiety and depression at the top. if you have migraine, you have two to three times the chances over the normal population of having anxiety or depression. I think part of it's a complex mixed picture here. Some of the problem is that there's some sort of genetic predisposition. There's similar sort of biochemical pathways involved. The chemical serotonin often comes up. So I think there are similar genetic underpinnings to both migraine and depression. But obviously, if you're getting lots of migraine, you get more depressed, you get more anxious. If you get more depressed and more anxious, you get lots of migraine. So there's a bit of a vicious cycle. So it's a complex mix. But certainly, I think it's a really important thing to make sure that has been addressed if you do have either anxiety or depression. So there's lots of other things that these reflect, many of these things reflect the fact that pain signals aren't modified quite so well. Now, as pain signals go up to the cortex, the surface of our brain where they are recognized, all sorts of modulatory factors are taking place. And you can just, the classic example here is someone who is had their leg shot off in battle. It just keeps going because they can't feel the pain because of this the way the brain is coping with the pain. So there's a big influence on the pain fibers and the pain sensory inputs that are going up through to the brain. And it seems that people with migraine have problems controlling and transmitting these signals. They don't filter them out as well as perhaps they could do. And these cause other painful conditions, particularly things like irritable bowel syndrome, fibromyalgia. Both these things are not uncommon in people with migraine. Then there are other things that are related that aren't necessarily due to pain. There's an increased risk of asthma, epilepsy, restless leg syndrome, sleep problems, all sorts of sleep problems. Restless leg syndrome is fairly common in people with migraine. This might not be recognized or even diagnosed. So if you're at nighttime, you're always fidgeting, or if your legs feel like they've got worms crawling up them or ants on them, or during the daytime you can't keep your legs still, that's restless leg syndrome, and there is a good treatment for that. And if you have restless leg syndrome, that's going to feed into the fact that you're going to have sleep problems. And sleep problems are quite common with migraine for a number of reasons other than restless leg syndrome. And again, that's a complex problem. If you have sleep problems, you get more anxiety and depression, and you have more migraines, so you don't sleep quite so well. So you get yourself into a vicious cycle. We're beginning to realize that with many things in medicine, not just migraine, there's an increased risk of adverse childhood events. I'm not obviously saying that everyone's had adverse childhood events, but we do recognize that adverse childhood events actually can impact upon diseases later in life. Dizziness or vertigo is an increasingly well-recognized complication of migraine. We think, well, I think probably just like the person with migraine has an increased sensitivity to light or sound, there's an increased sensitivity to balance. So I think it's all part of this migraine package, which we're recognizing increasingly. And the other interesting thing we're also recognizing, and there's probably going to be one or two of you here, and I'll be interested if there are people with lax joints. We're recognizing a connection between people with lax joints. Are you double jointed? Can you push your fingers back? Can you do the splits? And these people with lax joints have a whole constellation of problems. Lax joints, migraine, a thing called POTS syndrome, which makes you feel dizzy and feeling faint. They have increased inflammatory problems, so they get wheals when they mark the skin. So the picture is one of migraine, lax joints, brain fog, fatigue, feeling lousy, dizziness, skin issues. If you have that constellation of problems, it's not being named, but it's becoming well recognized. And the problem with these people is that they get pushed around from specialty to another. No one takes overall charge of what's going on. And in many cases, the combination of these symptoms is not recognized. And it'd be really interesting to know if there's anyone here today who recognizes that, which is becoming increasingly important to us. So those are the main migraine relationships. The other one I need to flag up is, which I'm sure you're aware of, is medication overuse for headache. And this is an important thing that goes with migraine, particularly when migraine becomes chronic. What I should have said when I was talking about diagnosis is we recognize migraine is then subdivided into migraine with or without aura. So about 30% of people will get an aura, usually a visual aura, but it can be anything else, pins and needles, weakness. 70% won't get an aura. And migraine can be, again, subdivided into episodic migraine and chronic migraine. And the definition of chronic migraine is headache on 15 days a month or more, of which 8 is migraine. So I should have actually mentioned those during the diagnosis, because medication overuse headache is very common with chronic migraine. It occurs in 3% of the population, which is a lot of people. I think it was number 17 in disabilities of the world. And it occurs if you take painkillers on more than 15 days of the month, for more than 3 months for your migraine, or triptans on more than 10 days of the month on a regular basis. And this is what tends to happen. So your migraine attacks get increasingly frequent. You start taking more and more painkillers. So you get this murky background blue headache of a medication overuse headache with migraine poking through, which leads to quite a complex presentation. You've got to get yourself off the painkillers and get back to your normal migraine, which can be treated appropriately. So I'm not going to say anything more about that, except it's important to recognize it. And it's quite a common problem and quite a common association with chronic migraine. One of the things we recognize is that if episodic migraine, that's migraine that comes with patches in between of periods when you get no pain, if that develops into chronic migraine, you tend to get changes in the brain. These changes are reversible with proper management. These can be reversed, but we can identify changes in the brain, which makes the migraine more difficult to treat. It's often, chronic migraine is often associated with medication overuse headache, and understandably, as you get more and more migraine and you go into this chronic migraine spectrum, you get more sort of social problems, more psychological problems. So the whole thing is a complex mixed mash of biopsychosocial issues. And it's really important to get to grips with chronic migraine because it really is quite impactful in terms of quality of life. So migraine, not just a headache, but a whole disease to be taken seriously, associated with lots of other disease processes. So I want to shift on now to my third section about how to live with migraine, which is about shifting the locus of control. I think the first important thing to understand is there is no, at the moment, we have no cure. You need to take more control over your problem. I think a useful way of seeing this is, a lot of people see migraine as the beast sitting on their shoulder waiting to pounce, and they're always fearful and anxious that it's going to happen. What you need to do is to get the beast under control. So the locus, this concept of locus is a geometric one. It's the center of the tension should be getting the beast from off your shoulder to living in the kennel. But when he does come out, as which inevitably he will come out, you're quite happy to put him on the lead and keep him under control. So I think that's quite a nice way of thinking about how we shift the locus of control. It's an understanding of what's going on and you taking control of the problem rather than the problem controlling you. So shifting the locus of control, you need to get the diagnosis correct. You need to understand what's going on. And then you need to be aware of the positive actions you can actually take to help. Let's just say a little bit about understanding what's going on. I don't want to go into this in any great detail, but as I've alluded to, migraine is a combination of genetic factors interacting with environmental factors, which give rise to migraine. So there are about 30 genes that have been recognized as important, acting in a complex way. These interact with environmental factors such as changes to your environment, specific triggers, which trigger off the migraine and give this complex picture of nausea, vomiting, light, sound sensitivity, and all the other stuff that goes with migraine. We recognize that there's a migraine generator at the base of the brain, and this shows a brain scan that lights up this migraine generator. And this is where migraine seems to start from. Now, we've all got this migraine generator. It's just that people with migraine have a much lower threshold for this getting fired than people that don't have migraine. Fortunately, I don't get migraine, but if you stimulated me enough with various chemicals, I would get a migraine. I have a migraine generator, but my threshold is higher than people who get migraine. There's two important implications for this center of the brain. One of them is that the nerves from the neck and shoulders come into this area as well, and they're all mixed up with the migraine midbrain center, what we call the cervico-trigeminal complex. So virtually, I can guarantee that virtually everyone here watching this will have neck and muscle pain in their shoulders and neck, and a large majority, I wouldn't mind betting, if you've been to see a chiropractor, an osteopath, and had all sorts of stuff done to your neck, thinking you've got a primary neck problem. But in fact, what this is the migraine generator sending out signals. It's not ticking off and firing a migraine, but it's actually acting. It's sort of ticking over and sending signals out of these nerves that are actually originating from the same area as the migraine generator, causing muscle tension and muscle pain. And that probably feeds back then again into the migraine center, which stimulates a little bit more. So you get this complex back and forth, but there's actually nothing wrong with your neck or your shoulders. It's all coming from the migraine center. So in my book, all this neck pain that we see virtually in everyone that we see in clinic is part of the migraine process rather than anything wrong with your neck or shoulder. So that's where things get triggered off from. And we're beginning to unpack these other, I won't go to this slide in any detail. I'm sure someone will talk to you about this another time, but this migraine generator fires off. And then we get this aura, which is a wave of electricity coming across the surface of the brain. And depending on which bit of the brain the wave of electricity is going across, that's the aura you'll get. So the most common type of aura is at the back here, which is where the visual cortex is. And this wave goes across at 3 millimeters a minute. You can actually measure it. And as I said, depending on the part of the brain it goes across, that's the sort of aura you get. There are no pain fibers in the brain itself. You can stimulate the brain to your heart's consent. You will get no pain from the brain. The brain is actually coming from the blood vessels in the lining of the brain, which we call the dura. So what happens in this process, excuse me, the migraine generator fires off this, what's called the trigeminal nerve, which causes inflammation of the blood vessels at the lining of the brain. And it's the inflammation that causes pain. So it's a complex picture, which we're beginning to unpack. So understanding is the first. The second, knowing what you've got, understanding what's going on is the second important point. Just to go back to this migraine generator, the point I missed, that right next door to this center is where the stomach reflexes are organized. So as soon as this starts firing off, you get signals going down to the stomach. You get what's called gastric stasis. So the stomach gets inhibited. So this is why you get nausea, in some cases vomiting, and in some cases the vomiting is actually worse than the pain. And the big clinical implication for this is anything you take by mouth, it's going to get poorly absorbed, it's going to get held up in the stomach. So anything, I always say that every time you have a migraine, you must take an anti-sickness medication as well, which helps settle this down and move the medication on into the bowel where it gets absorbed. Things don't get absorbed in the stomach. They just get held up there. So two important implications for this. One is the neck and one is the stomach. So let's move on to what you might like to do or might think about for shifting the locus of control. So first things are triggers. Now, I'm not going to say anything about triggers. I mean, there's some in the books, everyone says cheese, chocolate, red wine. A lot of people spend a lifetime looking for the elusive trigger. If the trigger is not obvious, then don't spend any time looking for it. Or some people do have triggers which they avoid, but in many cases you will not identify a consistent one. But what people don't realize is that you need to keep your environment both internally and externally as constant as possible. People with migraine don't respond to changes in things very well. So external environment, I'm sure you're aware of this, changes in stress, changes in sleep patterns, changes in atmospheric pressure, humidity, all sorts of things happening. A lot of people have a very stressful week, but nothing happens. They go home for the weekend and off goes the stress and on comes the headache. So it's these shifting patterns that the migraine's brain doesn't deal with very well. So that's the external environment. The internal environment shifts in glucose level, hydration, water levels, hormone levels in females, obviously, menstrual migraine, menopausal migraine. These are due to shifting patterns of estrogen. So you need to keep your internal environment as constant as possible. So regular small meals. This is particularly problematic in children who skip their breakfast and don't eat regularly. Regular hydration, regular sleep patterns. Keep things as constant as you can. Difficult in today's modern era, but I think it's important, and I think that's far more important than triggers. Lifestyle is certainly important. I think from a general perspective, I think weight is really important. We recognize there's a relationship between migraine and obesity. So I think weight, healthy diet, exercise is really important. There's quite a lot of evidence to suggest that exercise does help migraine. None of these things are the ultimate answers, but these are all things that will help you get charge of your problem. The other thing you need to do is address your comorbidities. And I think we've talked about this, the really important, and I'm not saying everyone has problems with anxiety and depression, but it's certainly important to get to grips with these. So our next next way we might like to think about shifting the locus of control is psychological approaches, not just to pain, but anxiety and depression. This is getting an increasingly important area as people don't like taking tablets. And just very briefly, what we got here on option in psychological approaches to the brain, there's three simple sections of the brain. There's our conscious thought processes, there's our subconsciousness, what goes on there, who knows, and then there are our emotions or our feelings. And there are three different approaches to psychological approaches. The psychotherapy will look at our subconscious. They would start exploring our subconscious mechanisms. So this might be quite useful if there's a past history of childhood trauma. Cognitive behavioral therapy will look at our thought processes. You know, we don't have to think the way we do, so it will try and restructure the way we think about things in a more positive way. And the other thing that's getting increasingly focused upon is this concept of mindfulness, and this focuses not on thoughts as changing our thoughts, but trying to look at our thoughts as they are and not attach emotions to them. So that the importance here is looking at the concept of time. So mindfulness looks back, and attaching emotions to negative thoughts would be depression. Attaching emotions to positive expectations about the future would be anxiety. And mindfulness tries to teach us to live in the present, to see our thoughts for just what they are. Don't judge them. Don't attach positive or negative emotions to them, and just take them for what they are. So that's a very brief snapshot of how things are. But certainly mindfulness attached to cognitive therapy is very much first line of psychological approach to treatment for both anxiety, depression, and also pain. So I'm not going to say anything more about that. It's a very specialist area, but that just gives you a snapshot of what's going on. Then there's a range of alternative approaches. Acupuncture, there's evidence to suggest acupuncture can be helpful. Homeopathy, there's no evidence for any of the others, but that's only scientific evidence. I'm not saying it's not helpful. And then there's a whole range of stuff like magnesium, coenzyme Q10. There's an information sheet for that on our website about alternative medications you may like to look at. Butterbeer, feverfew, not strong evidence to support their benefit, but some people find them helpful. Then there's drugs, which is going to be dealt with in other times. I'm not going to say anything about that. And there is an increasing interest in electrical devices you may have heard of. These are not mainstream yet, although for cluster headache, vagal nerve stimulator is available on the NHS, but there are no electrical devices as yet available for migraine on the NHS, although you can buy a device called Kefali for about £200. So I think that's the third element of things you can do to live with migraine. Understand what's going on, take control of your migraine. So the migraine is not in control of you, you are in control of your migraine. Just to pick up on drugs, there's a very bright future for migraine. I'm sure you picked up on these CGRP antagonists, and they are looking really very promising as a treatment option for the prevention of migraine. So that will be dealt with, I'm sure, another time. Sorry, that's gone on rather long, but I'm very happy to take questions on any of that.
Lovely, thank you, David. I think that's really helpful. There's certainly been a lot of good chat in the chat box. I forgot the word for it then. So I have got a note of some of the questions that have been asked already, and obviously please feel free to pop in questions. But probably, David, if it's worked for you, if we just go through them.
Yeah, sure.
Yeah, so the first one is around pregnancy and treatment. So someone has been on Pazotafen, found out recently that they're pregnant, congratulations, was initially advised to stop taking Pazotafen, but after speaking with their GP is currently continuing with them. And they were wondering if there were any further or recommended medicines that would do the same job as the Pazotafen that we know is safe during pregnancy.
Yeah, I think if you're pregnant, it's probably best to get specialist advice. Now, that's easier said than done because there's not always headache specialists around. But the drugs we use for prevention that we know we're safe in pregnancy are the triptans are fine, propranolol and amitriptyline. There's an information sheet on our website about management of pregnancy, and I think probably you might like to look at that, would be your best bet. But it is a tricky area. We need to proceed with caution. It's probably best for a specialist to be involved, or there's no reason if the GP is confident he can't manage it. But the drugs you would use are propranolol, amitriptyline, and triptans, and I probably I think Pazotafen is okay, but I think the other two would be preferable.
Lovely, thank you, David. That's very helpful. And the next one is someone who has only triggered the migraine response following a brain hemorrhage in their 50s.
Yeah.
They want to know what preventive treatments are available, as they can't take triptans or Botox. They don't really get the pain, but they struggle with the other chronic migraine symptoms.
Yeah, this is interesting, things that trigger off migraine, and we're beginning to become aware of insults to the brain can trigger migraine, particularly trauma. Often lots of people, they hit their head and migraine came on. And I think we've all got this migraine predisposition, and insults to the brain like a bleed or a blow to the head can trigger off migraine. What drugs are available? I think these new drugs, the CGRP drugs, would be fine for that problem. Soluble aspirin are good, paracetamol is good, taking an anti-sickness medication, but the new group of drugs are going to be quite promising. I think I would actually suggest that is explored for that issue. I think that the person needs to see a specialist with interest in headache. That's a challenging issue, but I think these new drugs are promising.
Lovely. And then a couple of questions around diet, any diets that help, and someone saying presumably a fasting diet is not a good idea.
No, fasting diet is certainly not a good idea. And I think Ramadan, I think we're going through Ramadan at the moment. That's clearly going to be a real challenge for people with migraine, and there really isn't a simple answer for that. Migraine has been, diet's been the thing that's been knocked around for some time. Certainly there's no evidence that food allergy is an issue at all, so we can scrap food allergy. But do diets help migraine? Well, there's been no proper studies on this, but a lot of people have suggested that what's called a ketogenic diet can help. This is a diet that uses fat to burn fat off for energy rather than glucose. So that would be a sort of low glucose, high fat diet. There's a lot of people suggest a balance between the different omega fat combinations. And the other diet is a high sodium diet. You need to be a little bit careful with that. You need to monitor your blood pressure, but these are diets that have been suggested that will help people. There's no reason, if there are no medical contraindications, why you shouldn't try them, but there is not good, sound scientific evidence to support their use. So when I say that, it doesn't mean to say they're not going to help some people. It's just that the proper studies haven't been done to show whether they're effective or not.
Lovely, thank you, David. And a few questions around triptans, around the best way to use a triptan, and also what the limit is for medication overuse headache, and someone asking specifically if you can use it for more than 72 hours if the migraines don't go.
What you're going to be, there's no reason why you can't use it, but the problem is more than 72 hours. But the problem is if you're using more than 10 days, it's actually not the number of tablets, it's the number of days of the month. If you're using on 10 days or more of the month, you're going to get into trouble with medication overuse headache. And if you're using frequent triptans, really that's a marker of poor control, and you should be looking to get better control from preventative medications.
Lovely. And any advice on the best way to take the triptans?
Well, always take them with an anti-sickness tablet, always, 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 and the sooner you can take them, the better. They work well with soluble aspirin or soluble paracetamol, and there are different, and be aware of the fact there are different formulations of triptans. The melts are the ones that melt in your mouth are for convenience. Everyone thinks they get absorbed through the mouth, but they don't. They're for convenience only. So you still need to take an anti-sickness medication. If nausea or vomiting is a major problem, then you can think about nasal sprays, which bypass the stomach, or even Migraine injections. So there are other formulations to think about as well, which can be taken into consideration. But always, always, always try to take your triptan as soon as possible. I always take it with a anti-sickness medication, which you'll have to get from your GP. Well, you don't have to get it from the GP. You can actually buy Buckerstam over the counter. There's also a little booklet on our website about what you can do to manage your own migraine. You can actually buy a triptan over the counter. You can buy an anti-sickness over the counter. You can buy soluble paracetamol and soluble aspirin. That's a really good combination.
Lovely, thank you, David. And there's been quite a few questions around the menopause and the perimenopause stage, with a lot of people saying there's not a lot of information about it. And if you can give some recommendations on the best way to manage migraine during the perimenopause and the menopause.
Yeah, it's a difficult problem. There's no difference to managing migraine at that stage than any other stage. So preventers, triptans are your first line of treatment. But if it's clearly a menopausal problem with menopausal symptoms, then we can do a number of things. We can use an HRT patch to smooth, or HRT gel to smooth out this fluctuation, because it's this fluctuation in estrogen that's not doing well. What happens is GPs often get a bit of a feeling that this is to do with estrogen, and they give estrogen tablets, which actually make the fluctuations worse because the tablets get absorbed and like this. You've got to have a nice smooth level. So estrogen gel or estrogen patch, starting low and building up slowly, can be quite useful. And there's no reason why you can't take, there's no contraindication to using HRT with migraine or migraine with aura. So I think HRT would be used properly and appropriately. Again, there's an information sheet on our website about that.
Lovely, thank you, David. And a few questions around vomiting and nausea, people wanting to understand a bit more about why that happens and how best to manage it.
Yeah, so there's, as I alluded to, there's the nausea or the stomach center is right next door to the migraine center. So the stomach closes up, closes off, that causes nausea and vomiting. So you have to have an anti-sickness medication. The options are metoclopramide, which is prescribable only, or a medication called prochlorperazine, which you can buy over the counter under the trade name of Bucostem. Domperidone we used to use, but we've gone off that a little bit recently because of some side effects, which I think are quite minimal. But metoclopramide is probably the main drug of choice, which you have to get from a GP.
Lovely, thank you, David.
If vomiting is significant, then you need to use, as I said, Migraine either nasally or through an injection.
Lovely, thank you. And lots of questions around the CGRPs. So in terms of what do you think about them and access to them?
Yeah, I mean, I don't want to spend too much time on that because I know you've got another section on treatment, so this isn't really about treatment, but the CGRPs have been a revolutionary development, probably the most significant development since triptans in the 1990s, and people have been working on a design of preventative drug since the 1990s, and this one has come up. It's an injection. You have to self-inject yourself every month, and NICE have acknowledged it can be used in the NHS, providing you have failed 3 previous treatments. Now, the problem is it's very expensive. It costs about £350 a month. And if you work out on the back of an envelope how many people would benefit from it, that's going to cost the NHS billions of pounds a year. So, you know, it's a bit of a nuanced problem. But if you've tried 3 preventative medications recommended and they have failed, then you are eligible, whether you have episodic or chronic migraine, for these new molecules. They're very exciting. They're a very big development. They're virtually free of side effects. Nothing is free of side effects, but they're quite, they're very good side effect profile. About a third of people will impact massively on their lives. That will be sort them out. A third of people will get a reasonable response, and a third of people probably won't respond at all. But there is some evidence that if you shift to another one, you might get a better response.
Lovely. And quite a few people who are saying that they've obviously had migraine for a long time, and they're sort of in their mid to late 60s and older, and they're still having regular migraine. Oh, someone's being loud. Should they hope that it settles down, or will it stay like that? And what kind of treatments would you suggest for people over the age of 65?
Well, statistically speaking, migraine will get better as they get older. You just got to be a little bit careful as you get over 65 because there's more other stuff going on. Triptans are not licensed for those over 65. It doesn't mean to say we don't use them, but there's always a concern because one of the problems with triptans is they can constrict the blood vessels. And as we get older, our blood vessels get more furred up. So I think like everything else in life, you've got to take the balances again. You know, you've got to weigh up the pros and cons of things. And I'm quite happy to providing no one's got any other underlying heart disease or other vascular issues, I'd be happy to prescribe a triptan if it makes a big difference to them. Preventive agents, they can be used, but we can be cautiously optimistic, statistically speaking, that migraine will get better with age, although some people, I'm afraid, it's quite rare to have migraine as you get older.
Lovely, thank you, David.
I just saw something in the chat room. I'll just finish off about CGRP. How do you get CGRP? This is really, now at the moment, we're still in the very early stages of access because it's only just been introduced. The local groups, primary care groups that pay for these things are still getting their act together because everything at the moment is very much COVID focused, but you can only get them from neurology specialist centers. So you will have to be prescribed, you have to be referred to a neurologist by your GP, ideally a neurologist who has an interest, but there's all sorts of issues with funding streams and payments. The local community CCGs have 3 months, once NICE have said, to get this sorted out. So very soon, you should be able to go into your GP having failed 3 preventers, and you need to take preventers at maximum doses you can tolerate for at least 8 weeks before you say this has not worked. Lots of people stop too soon. Then you have to keep a migraine diary for 3 months, and then your GP can refer you to a neurologist. It's always best to try and find a neurologist or a clinic like ourselves with an interest in headache, if you can. And the Migraine Trust have got a list of these people. So you need a specific headache referral, really.
Lovely, thank you, David. And any comments on migraine and the COVID vaccinations, specifically the AstraZeneca vaccination?
Yeah, it's a really tricky one, that, isn't it? Really, it's going to make your migraine worse. It's like this insult to the brain. You know, it's like your hemorrhage or it's like your trauma. It's going to insult the brain. The problem we're concerned about is these blood clots, and they can be excluded simply with a blood test because they tend to have low platelet levels. So you can exclude them with a blood test. And they're very rare over the age of 40, but there's no doubt that COVID and COVID immunization can exacerbate your migraine.
Lovely, thank you, David. And a lot of people are saying they have hemiplegic migraine, and any advice or recommendations for the best way to manage and treat that one?
Yes, for hemiplegic migraine, you need to see a specialist center. This is quite a complicated. You need to proceed with care with hemiplegic migraine. It's an aura, just like a visual aura or anything else, but this needs to go and see a specialist. There is a drug called flunarizine, which is widely used on the continent, but unfortunately not available in the NHS under license, although we can prescribe it from a headache centre. So if you have hemiplegic migraine, you need to see a neurologist or a headache specialist.
Lovely, thank you, David. And lots of people picking up on obviously the comorbidities. I think that resonated with a lot of people. A couple of questions around that. If ME or chronic fatigue syndrome is likely to be a comorbidity?
Yes, it's all part of this package. I mean, it is definitely fibromyalgia, ME, migraine. We don't really understand what's going on, but I'm just interested, does anyone recognize this problem of lax joints, feeling ghastly, brain fog, skin problems, migraine? Yes, I can see quite a few nodding heads there, actually. Yeah. This is really difficult because no one will take responsibility. I don't know if this is your experience. No one will actually take overall responsibility for this. This is a genuine syndrome that we recognize. It's tricky.
Yeah, thank you, David. There was lots in the chat box where people recognize that, I think. And someone's asked, can the symptoms of migraine, especially aura, cause long-term damage of the brain, or will it cause long-term vision problems?
Aura, we're beginning to unpack aura seems to be it's a different kettle of fish to migraine. So with aura, you have a slightly increased risk of both heart issues and stroke issues, although the increased risk is small. And this increased risk seems to be carried by young females, where the actual background risk is quite low anyway. So although there is an increased risk, the change is still quite small. But there's no doubt that migraine with aura does carry a slightly increased risk in these problems. If you look at 1,000 people with migraine with aura and 1,000 people with migraine and 1,000 people without migraine, and you follow them up through their life, their actual number of years they live is no different. So it doesn't cause any difference to your mortality, but there is a slight increased risk in particular these vascular areas, but although the risk is quite small. That's why it's important you don't smoke, you don't take the combined oral contraceptive pill, you keep your weight under control, you exercise, so you make sure all your other risk factors are, your blood pressure is okay, blood glucose is okay. You've got to make sure all your other risk factors are addressed.
Lovely, thank you, David. And someone's asked if there's any studies checking effectiveness of medication against different genes, taking advantage of the large genetic studies of for example, the UK Biobank. Yeah,
that's a top question. In fact, the answer is no. We're always looking for, and we have been searching for ages with the preventers we've used, can we recognize any features of people that make them particularly going to be responsive to this particular agent? And the bottom line is we don't have that information, and those studies have not been done. Although it's really important, if we could tease out who would respond to what, that would be really a huge step forward. The same with all elements of medicine, in fact, but we're not at that level of sophistication.
Lovely, thank you, David. And could you comment a bit more on managing restless leg syndrome?
Yes, well, the first thing is to get the treatment correct. The second thing is there are two good medications to treat that appropriately, and it can make a significant difference to people's lives. Ropinirole is one, and the other is, can't remember, but there are two medications.
Lovely, thank you. And someone says they have had a tender and sore scalp for many years. Can this be part of the migraine?
Yes, it's a condition called allodynia, which is a heightened sensitivity. So just as you get heightened sensitivity to sound, heightened sensitivity to light, heightened sensitivity to movement, you get hypersensitivity to touch. And this is quite common during a migraine And if you have allodynia, if you have this increased sensitivity, you're more likely to get chronic migraine, and you're more likely to get other, I'm not saying you're going to, but you're more likely to have other painful conditions like fibromyalgia, irritable bowel syndrome. Let me just go back a second, something I hadn't recognized, which I'm getting increasingly interested in, this concept of visual stress. A lot of people are light sensitive, and a lot of people don't modulate sensory signals coming through from their vision that well when they have migraine. And this phenomenon of migraine stress is recognized. So a lot of you will not like headlights at night time. You might find difficulty in reading, looking at the computer. And there's a problem. It's called Irlen syndrome, and it has been suggested, it's slightly controversial, but you can get certain colors of filters will help this. It's the same. It's been found similarly with children with dyslexia. I don't know if you've heard that they can put filters over the page, and this makes their reading much easier. Because black on white is really not good for migraineurs. Because if you think about it, we have evolved to adapt to soft shapes out in the environment. We come into the cities and looking at books and computer screens, it's all verticals and horizontals, and they're changing all the time, and it's black on white, and this causes visual strain, which can exacerbate migraine. So I'm sending more and more people to get their eyes checked with a colorimetry. I mean, you can buy colored lenses online, but you really need to get things checked. And I think this can help people. So visual stress is quite an important feature.
Thank you, David. I'm just going through the questions. I think someone was asking what your thoughts were on Botox.
Yeah, I'm just picking up this thing on restless leg syndrome and iron, which is, yes, that is correct. Iron deficiency anemia, because restless legs all to do with dopamine, and low iron can cause dopamine issues, which can cause restless leg syndrome. So if you have restless leg syndrome, you must always get your iron levels checked. Botox is licensed for the management of chronic migraine. Historically, it was on its own in the field. It now has strong competition from these new CGRP molecules. Botox can be really very helpful in a lot of people, but it is only licensed and it only works for people in chronic migraine. You need to have, I think it's about 30 injections, I can't remember how many, across various aspects of the face every 3 months. But I suspect as things go forward, and there's going to be a bit of a commercial scrap out there, because what I think is going to happen is the people that make Botox will reduce the price and undercut CGRPs. But going forward, I think Botox will be overtaken by the new CGRP molecules.
Lovely. And a question that's come up a couple of times is that a lot of the COVID vaccine blood clot symptoms are similar to migraine symptoms. Should people get their migraine checked out? Should they get every migraine checked out after the vaccine, as a non-migraine sufferer may be inclined to?
No, I think it's a really difficult one. That we can't have everyone. If you've got to 12% of the population having migraine, and quite a significant number of people getting headache after the vaccines, we can't have the whole, half the population. It's not going to. I think if there's any significant shift in your migraine, if it's just your ordinary migraine, then I don't think there's an issue. But if you get a migraine which is really significantly different, the pain goes on for much longer, it's really very much painful, I think that's worth flagging up. But if it's just your normal migraine pattern, I don't think there's an issue there.
Lovely. And a few people have picked up on the points around neck pain and wondered if you had any recommendations about how to manage that.
Yeah, treat the migraine. I think massage will be helpful. Don't waste your money on chiropractor or osteopath. I think migraine prevention, treat it as if you would migraine.
Lovely. And is there a reason why migraine is triggered during sleep and people wake up with it?
It's just the way things happen. It's probably changes and things. I suspect that during sleep, your glucose levels are falling, your hydration levels are falling because you're not keeping these up. So it's probably due to things not being constant. And again, when you're waking up, there's a surge of various hormones which wake you up, and your blood pressure starts rising. So the answer is that is not really known, but I suspect it's probably a reflection of your physiological changes that are occurring during sleep, triggering you.
Lovely. And I think the restless leg treatments wasn't quite heard. So could you repeat those?
Well, there are 2 drugs which I haven't got. Ropinirole is one, and there's another drug. These are 2 drugs, so you can look them up. They'll be online. So it's specific drug treatments, and make sure you haven't got iron deficiency anemia.
Lovely. And what do you think about the nerve end blocking injections?
Yeah, peripheral nerve injections are really useful. They're particularly useful in cluster headache. They don't work quite as well in migraine, but they are very useful. We inject either the nerves at the back of the neck, or the nerves at the side of the neck, or the nerves at the front of the head with local anesthetic or steroids. And this can be very effective in some people up to 3 months. It's not a cure, it's not a long-term treatment, it's quite useful getting someone under control while the migraine preventive medication is going on board. So yes, they are useful. We use them quite a lot. Yeah, so yes, they're good.
Lovely. And any advice for sinus pain?
Sinus pain, 85% of sinus pain will be migraine. There's 2 studies that suggest that chronic sinusitis is usually misdiagnosed, and 85% of the time it's actually migraine. So if you have chronic sinusitis, a lot of people have had their sinuses drilled out, this, that, and the other, and the diagnosis of migraine has been missed. Migraine headache can radiate to your sinuses, it can radiate to any parts of your head. Yeah, I'd be very suspicious that a sinusitis problem is not migraine. I'm not saying that people do get sinusitis, obviously, but it's often misdiagnosed.
Lovely. And lots of people saying thank you, David, for a fantastic presentation, which I echo. Any comments on how to manage the allodynia and possible treatment options? Well, there's no magic treatment options for that. You have to treat it with migraine prevention. It's part of this migraine engine ticking off, and the only way to sort that out is by addressing the migraine motor ticking, which means migraine prevention. There's no other way forward than that. Lovely. And a couple of questions around long-term use of medication and what's safe, both in terms of triptans, but also in terms of preventive, such as topiramate.
Yeah, I mean, there's no evidence to suggest that these things are harmful in the long term. We've always been a bit concerned about triptans due to the fact that they blood vessels. But there's been a big study in America recently looking at people using triptans over very long periods of time. There's been no increased risk of heart disease or stroke or heart attack. So it looks like all the drugs we use are, I mean, all drugs have got side effects. There's no doubt about that. But most of the drugs we use, the side effects will occur in the first few months. But there's no evidence. I'm just trying to think now. There's nothing long term about any of the stuff we use that's going to cause a problem.
Lovely. And a few questions around computer screens, an increase in migraine during the pandemic and possibly being linked to computer screens, and any solutions for that.
Well, some people say you can certainly get checked for visual stress. I actually changed my screen. I tried it because I'm lazy. I don't do it every time, but I've got black on white at the moment, and even for me that doesn't get migraine, it's a bit. So I've been experimenting. You can actually change the color of your font and the color of your background, and try and experiment with just putting a much, like a nice gray or a nice, so see what feels right to you. But it's this black on white that really isn't helpful, I'm sure. You can get screens that put in front of computer screens, but nowadays there's no flicker on computer screens. In the old days there used to be flicker, but I think that's all gone now. So I would experiment with black and white. I mean, I think COVID's been complex because migraine has been driven by obviously more computers and certainly screen time, particularly in kids. Last thing at night is a disaster. But also increased stress levels of course migraine, and I think it's a complex combination of things really. But experiment with your screens.